So it's my pleasure to introduce our colleague here from the Czech Republic, Jitka Klugarová, which I'm pronouncing terribly, I apologize. She is the deputy head of the Methodological Center of the National Institute for Quality and Excellence in Healthcare, which is located within the Institute of Health Information and Statistics here in the Czech Republic. She's a co-founder and deputy director of Cochrane Czech Republic, Czech JBI Center of Excellence, and the Czech Grade Network, and holds a position as an adjunct associate professor of public health at the University of Adelaide in South Australia. She has a clinical background in physiotherapy, biomechanics, and podiatry. Please join me in welcoming Jitka.
Good morning, everyone. Thank you, Drew, for a very nice introduction. Actually, I cannot really express with my words how privileged I feel today to stand here in front of you and have the opportunity to talk. I have no direct conflict of interest in the content of this presentation. I have only several intellectual ones. Today, the main aim of this presentation is to discuss how to find a balance between quality and time efficiency in guideline development and their utilization. I have chosen this question because I'm dealing with this question every day. For opening discussion on this question, I will use examples from our journey over past 10 years. We experienced challenges, etc. Past 10 years, we are mainly focused on everything around evidence synthesis, guidelines, including education of our clinicians, stakeholders, students. We are also involved in several methodological groups among these organizations, Cochrane Collaboration, GBI, Great Network, etc. And I cannot forget implementation, because as a physiotherapist, I'm very interested in implementation, and I want to see evidence get into the practice. Our journey started in 2007, and there has been two main breakpoints. One was in 2013, when JBI family welcomed us as a novice very warmly, and it's amazing to see three of them in the second row in front of me. So thank you. The second one was in 2017, when our current boss, Professor Dušek, not sure if he is with us, but probably not, approached us and said, "Hey, you're these EB guys in a Czech Republic. We are thinking about starting doing guidelines. Can you do it?" And we said, "I don't know, but maybe." As we attended in our Global Evidence Summit, when we got amazing new connection with Cochrane Collaboration and also Great Network, and been planning already to establishing center, we said maybe we can try. We are crazy enough to do it, so we did, and it got us here. However, none of it wouldn't be possible without collaboration and without support. All of these entities, what you've seen on this screen, because without collaboration it wouldn't be possible. And I really loved yesterday when Isabel explained how she feels about collaboration. That collaboration is to meet the right people at the right moment and put aside the pride. And it was exactly what we did. We were really lucky to meet the right guys to support us. So we started in 2017, and as you can see on the screen, our starting point wasn't really good. There was high heterogeneity in a level of care, inconsistency if level of guidelines. However, we looked outside and we've seen that there are already many organizations who are several years ahead of us. So we asked for help and we learned. And we developed a national methodology for guideline development based on EBH principles, and we started. We've been able in 5 years to complete 41 guidelines, mainly adopted. However, it was really time consuming, especially because we had lack of methodologists and also our clinical teams, which supposed to work with us, were very overwhelmed. As you've seen, in most of elements, we started from the zeros, which means no a unified methodological approach, for methodologists, guys who know something about EBHC, evidence synthesis, and know how guideline should look like. No really robust, trustworthy guidelines. I'm not saying that all of guidelines were evidence-based, they were not. However, the methodological approach wasn't unified. So we accomplished some achievement in this point. Again, and I have to repeat myself, it was thanks to sharing know-how and of course thanks of this very strong alliance which we were supported. In the meantime, in terms of implementation, thanks to strong JBI collaboration within Europe, and thanks to a very good friends in 7 European countries, we try to improve implementation science in this part, and we actually have been able in these 4 years completed over 50 implementation projects. However, just in the beginning, it wouldn't be implementation if there wouldn't be obstacles. So just in the beginning, COVID came, and in case of implementation, it's quite not easy to get change into the practice if there are many restrictions. However, we did it, and I'm very happy that actually representatives, friends from all these 7 countries I see sitting in this room, and I would like to thank you. However, still, there are still many tasks and very limited time frame. Yes, we were able to finish 45 guidelines in 5 years, but it's not enough. The majority of tasks, what we are getting, for example, from Ministry of Health and other authorities, are with a note, yesterday was late. And there are still unresolved urgent problems and still limited human resources. So we said, what we do now? And we said, oh, okay, probably one way is to put everything into one place. Again, we looked around, and there were already nice WHO, great working group, and organization like this many years ahead of us. So we got inspired and established NIKEZ as a National Institute for Quality and Excellence in Healthcare. Also, thanks to our current Minister of Health. You met him yesterday, and you've seen that he is very familiar with guidelines and how important they are. This is the structure of NIKEZ. There are many agendas. However, our agenda, it's a NIKEZ Method Center and ready guidelines and rapid recommendations. And we are very happy that we were able to establish NIKEZ International Advisory Board, which, for example, Holger Ispart, Zoe Jordan, Catherine Spencer, Miranda Langdam, etc. The Method Center NIKEZ, of course, not staying just on the field, really. It's really supported by Cochrane Czech Republic, JBI Center of Excellence, Czech Great Network, GIN, etc. And I'm very happy that recently, especially last year, it was strengthened collaboration within WHO, and especially last several days, there were very intensive roundtables discussion how to strengthen it even more. Because this is only way how to achieve, or at least try to achieve, synergy in evidence synthesis products, and also practical use. So if I summarize it, our vision, our idea is really put everything into one place, which means systematic developments of guidelines, rapid recommendations. We've developed a prospective central registry of all outcomes, including prospectively submitted protocols of all recommendations, evidence synthesis, and also rapid recommendations. All approval processes is part of it, and this register enables that. And also there's freely available our national methodology in Czech and in English. What is ahead of us and what we are currently dealing with? Within another project under NIKEZ, it's ahead of us to develop 100 sets of trustworthy national rapid recs and guidelines on the topic which are prioritized by Ministry of Health or medical societies, including also quality indicators, and implement them into the practice. In the beginning, we did quite funny mistake, because we've been asked in the beginning, there were a really urgent task from Ministry of Health, and we showed that we're able at some questions answer within hours and days. And from this moment, our current director wants only fast and dirty, and really answer within hours and days. What we use mainly is a great approach. However, we adopt and mainly adopt also non-grade guidelines if they are based on EBM principles. However, when we develop our first 5 pilot guidelines, we've seen that all of them, really each of them, use completely different expression of certainty of evidence and strength of recommendations. And we've been thinking what to do with it, because our end users, our clinicians will be really confused. Why? There's E, why there's direction up, why there's some ladder, or what does it mean? So we try to, for visual transformation into unified form. Don't make me wrong, it's not the shortcut. It's very transparent. It's just to ease the use to our clinicians. And Miloslav, as you remember from yesterday, this random amateur singer, is last several years very dedicated to great development with his group, and I think they did a really good job, including Holger, and also I see many colleagues from this group here. So and it's really amazing to see them here, because it really enables harness the work of others, and also prevent application and research waste, human waste, etc. I started with a question, and I will end with another one. Sorry for that. Just imagine a situation if there's no high-quality grade guideline. What would you do? Which philosophical approach do you identify more with? Would you really develop the novel grade guideline or rapid recommendation from the beginning, no matter what? Or would you prefer a development of the non-grade guideline if it's urgent to change the practice, and of course, if the guideline is developed transparently and based on EBM principles? Thank you very much.